شكرا جزيلا دكتور حسن. أهلا بحضراتكم. It's always a great pleasure to be with you. And in this talk, I will discuss physiology of cardiogenic shock with some practical thoughts on the topic. I have no disclosures. And the cardiogenic shock was found to complicate about 7% of myocardial infarctions. The incidence did not change over the last 15 years. So it's still high incidence, and it still carries high mortality, 40 to 60% 30-day mortality, which is very high. And it's still the leading cause of in-hospital death after myocardial infarction, despite all the advances in the diagnosis and management of myocardial infarction. And the only significant advance until now is probably knowing that early revascularizations improves long-term survival. And this is the finding of the shock trial. And we now understand also that the pathophysiology of shock is quite complex. So it's not simple one factor which contributes to the shock, but it's a multifactorial process. And one of the main challenges in cardiogenic shock is that performing a randomized controlled trial is very difficult. So what is cardiogenic shock? It is not just a low cardiac output state. It's much more complex than that. So it is multi-organ dysfunction, which is characterized by peripheral hypoperfusion, microcirculatory dysfunction, and also, importantly, a pro-inflammatory cytokine release. And one of the biggest problems is that once multi-organ dysfunction is established in a patient with cardiogenic shock, improving cardiac output is unlikely to improve survival. So time is really crucial in the assessment, diagnosis, and therefore the management of cardiogenic shock. And that is the cascade of events which happens in patients with cardiogenic shock. And you can see that once you start having systolic or diastolic dysfunction, depending on the pathway of dysfunction, a cascade of events will happen, which will include systemic hypoperfusion and hypotension if it's systolic dysfunction. It will include hypoxemia due to left-sided filling pressures elevation and diastolic dysfunction, and this will eventually lead to ischemia and progressive myocardial dysfunction and death. And in the process, systemic inflammation as part of the myocardial dysfunction will also progressively affect most of these steps in the cascade. And what we are missing in tackling patients with cardiogenic shock, we need to keep in mind that cardiogenic shock is not binary. So it's not shock and non-shock. It's much more complex and detailed than that. And I will discuss this in the next few slides. And it is also more than a pump failure, which entails macrocirculatory dysfunction, which is hypotension and the clinical criteria for dysfunction, but also microcirculatory dysfunction, which is very difficult to evaluate and monitor at the bedside. And also the time is very critical in estimating and diagnosing patients with shock. So it is not binary because shock is a continuum. And you can see here the proposed stages of cardiogenic shock, starting from a pre-shock phase to mild shock, to shock state, to profound shock, refractory shock, and eventually death. And the progression of shock over time could take from hours to days. And you can see each one of these stages of shock requires specific kind of therapies, starting from the pre-shock and mild shock phases, which really is essential to identify, because once you identify this pre-shock and mild shock stage, it becomes easier to stop the progression and starting therapies, which will eventually improve survival. And once you go into the shock or profound shock state, becomes more difficult and challenging to influence the progression and delay it. So primary heart involvement is quite important part of shock pathway, and the trigger is usually the beginning because it leads to substantial reduction in myocardial contractility, which leads to the cardiogenic shock syndrome. And a critical reduction in cardiac output could be estimated by evaluating what is called cardiac power output, which is the multiplication of both cardiac output and blood pressure. And it is found in the shock trial registry to be a marker of extreme LV dysfunction. A fall in the cardiac output below 0.53 is a robust and strong indicator of bad outcome. So that's an important marker when you estimate and evaluate the severity of cardiogenic shock. And also very important when we talk about cardiogenic shock is not to only think about the left heart, we need to also always think about the right heart, because right ventricle is a volume pump and it's not a pressure pump. And cardiogenic shock can present with or without pulmonary hypertension in severe right heart failure. And when we talk about the right heart, the other parameter which is recommended to be assessed to evaluate right heart dysfunction is the pulmonary artery pulsatility index, which is the pulmonary artery pulse pressure. That is the difference between pulmonary artery systolic and diastolic pressure divided by the right atrial pressure. And the normal pulmonary artery pulsatility index should be more than 1, which indicates high pulse pressure, which means good RV contractility and low right atrial pressure. But once you have pulmonary artery pulsatility index less than 0.1, this identifies significant right ventricular dysfunction. What about the microcirculation? It's a very important aspect and interesting concept, because we always assume that macrocirculation and microcirculation are coupled, working together in shock. But this is true only until a tipping point. There is a certain point at which uncoupling happens between the macrocirculation, which is a blood pressure and the apparent hemodynamics, and the microcirculation, which is a tissue-level hypoperfusion. And once we reach this tipping point, this will lead to microcirculatory decompensation, which triggers cascades of inflammatory mediators and a downward spiral of fatal cardiogenic shock and the refractory phase. And at this point, once you reach that uncoupling, restoration of macrocirculation does not improve microcirculation, which means once you uncouple, even if you keep improving blood pressure by inotropes, you become unable to improve microcirculation, and patients continue to deteriorate despite inotropes. And this might be familiar to all of us treating patients with cardiogenic shock. Some of them respond quickly to inotropes, some of them don't. And this is a study which was published about 12 years ago, looking at this uncoupling between the macro and microcirculation, and looking at the median perfused capillary index. So they assessed the microcirculation by quantifying the perfused capillary index, or the perfused capillary density. And you can see here that the perfused capillary density, more than 10, has a much better survival, the blue curve, compared to patients with a perfused capillary density less than 10. And that's a very important one. You can see the significant change in survival between patients with good microcirculation, the one in the blue curve, and those with poor microcirculation, the one with the red curve. And here you can see an interesting finding in the study that even with what appears to be similar hemodynamic profile between the mean arterial pressure in patients with reduced pulmonary capillary density, those with poor microcirculation, and patients with a good pulmonary, good perfused capillary density, which is a patient with normal microcirculation, the mean arterial pressure was the same in both groups. The cardiac index was almost closely similar in both groups, and the mixed venous saturation was almost similar. So you could see that these patients might have the same phenotype, the same numbers, but they are different because one of them has poor microcirculation, which is the one with reduced perfused capillary density, and the other one had a good microcirculation, which is the one with increased and normal perfused capillary density. And obviously now we know that survival is much poorer in those with reduced perfused capillary density. And this is the phase where the uncoupling happens, which is exactly around the shock stage. And this is what we're trying to achieve, to identify shock early at the pre-shock and mild shock phase, and maximum at the early shock phase, and not to leave it until it goes into profound shock and multi-organ dysfunction. And important also to look at evaluation of cardiogenic shock by the utilization of pressure volume loops. And this is from a Harvey simulator, which is available on iPad, which demonstrates the different relationships between pressure and volume in different hemodynamic states, including cardiogenic shock, and also in the context of mechanical circulatory support. And after looking at the normal pressure volume loop, you see in patients with cardiogenic shock, suddenly you see a significant reduction in the volumes and also a significant increase in the volumes and also increase in the pressures with a reduction of the stroke volume, which is the overall diameter of this loop compared to the bigger one with the normal stroke volume. And that's the difference between normal heart on your left-hand side with a normal relationship between pressures and volumes. And on your right-hand side, you see significantly reduced stroke volume and increased pressures and increased volumes. And also importantly, the ventricular arterial uncoupling, which happens when you have significant elevation of arterial elastance due to sympathetic overactivity in cardiogenic shock and reduction of ventricular elastance due to poor cardiac output. So it is not always sepsis, very important when you see a patient with cardiogenic shock who is inflamed, febrile, with increased inflammatory markers. Some patients have systemic inflammatory response as part of the cardiogenic shock. And they found that day 2, after cardiogenic shock onset, clinically overt inflammation was seen in 20 to 40% of patients, which is not due to sepsis, not due to infection, but this is due to systemic inflammatory response as part of the cardiogenic shock. And this will eventually lead to low systemic vascular resistance and difficulty to maintain hemodynamics. And microcirculatory injury in the intestinal barrier contributes to increased bacterial translocation, which will eventually lead to sepsis and multi-organ failure. However, 20 to 30% of cardiogenic patients were found to be complicated by sepsis. So sepsis is there in a category of patients, but we should always remember that if it's not sepsis, it is systemic inflammatory response. And this is the spectrum of cardiogenic shock, where you are looking into two distinctive parts of the spectrum. So one aspect of the spectrum is the hemodynamic problem, where you have hemodynamic profile of cardiogenic shock, which is actually the benign part, because this type of, or this spectrum of cardiogenic shock is the one who is more likely to recover. But on the other hand, this is the hemometabolic problem, where a patient develops significant metabolic and multi-organ dysfunction, and this is the patient who is likely to die. And here is the importance of phenotyping every patient with cardiogenic shock and then categorizing the requirements, whether it is pharmacological support or mechanical circulatory support. And here the four distinctive hemodynamic profiles of cardiogenic shock classified according to left heart filling pressures and right heart filling pressures. And you see whether it is biventricular congestion or left ventricular congestion or right ventricular congestion. And there is a category of cardiogenic shock patients who are interestingly hypovolemic or euvolemic. And also looking at the percentage of cardiogenic shock presentation and hemodynamic profiling, 50% of patients were found to be biventricular, followed by 24% to have left ventricular, and then 18%, which was found to be euvolemic or hypovolemic cardiogenic shock, and only 8% was found to be in isolated right ventricular cardiogenic shock. And the mortality of patients with cardiogenic shock, according to the congestion profile, was also interesting, because they found that patients with biventricular cardiogenic shock had the highest mortality, whether it's an overall mortality or after myocardial infarction or after presentation with heart failure. And they also found that the CVP was the main determinant of mortality in these patients. And it was higher, the mortality was higher in myocardial infarction than patients presenting with heart failure due to certain types of cardiomyopathy. And also importantly at the bedside, to look at hemodynamic profiling depending on the clinical presentation according to volume status or peripheral perfusion and peripheral circulation. So we have the cold and wet classic cardiogenic shock with a low cardiac index, high systemic vascular resistance and high wedge pressure. You have the cold and dry, which is the distinctive euvolemic cardiogenic shock, where you have low cardiac index and high systemic vascular resistance, but neutral pulmonary capillary wedge pressure. You have the warm and wet, which is the type of cardiogenic shock which resembles sepsis, where you have vasodilatation with low cardiac index and high wedge pressure. And you have also a vasodilatory cardiogenic shock, which is a classic cardiogenic shock where it is dry and warm with high cardiac index and low wedge pressure. And it's actually usually a not cardiogenic shock because it has more features of septic vasodilatory shock than cardiogenic shock because cardiac index is high in these patients. So they found in this study that classic cold and wet cardiogenic shock was the most common, and it was found to be in 2/3 of cases. And low cardiac index was not necessarily an end organ perfusion. Low cardiac index is not necessary to be seen, as end organ perfusion can be seen even with patients with high cardiac index. And they also found that cold and dry patients are often patients with chronic heart failure who are diuretic responsive with acute decompensation, and wet and dry phenotype with systemic inflammatory response and low systemic vascular resistance has a higher risk of mortality. And cardiogenic shock due to right ventricular failure represents only 5 to 3% of the shock trial registry. So I hope I covered what I wanted to say about understanding cardiogenic shock physiology and pathophysiology. And my take-home message from the presentation is that early identification and management of cardiogenic shock is crucial. And we need to keep in mind that cardiogenic shock is not just a low cardiac output syndrome. It is more complex than that. And maybe it is time to rethink about the microcirculation. And unfortunately, we don't have much more advanced tools at the bedside to measure microcirculation. Maybe the only available clinical parameters are capillary refill time, estimation or a measurement of lactate, central venous saturation. If we have the near infrared spectroscopy monitoring at the bedside, but we don't have other available monitoring tools. For research purposes in some parts of the world, they use sublingual microcirculatory assessment, but this is entirely a research area. We haven't used it in clinical practice as yet. And obviously this is an area of evolution. So we are hoping for more studies, especially in patients with non-ischemic shock, because most of the information and the data we have until now about cardiogenic shock is taken in patients in ischemic cardiogenic shock after myocardial infarction. And thank you very much for your attention.
شكرا جزيلا دكتور حاتم for this elegant lecture about the physiology and pathophysiology of cardiac shock. وهنفتح المجال for 10-minute discussion قبل الدكتور حاتم ما يغادر لشغله. مين يحب يسأل؟ يمكن ابتدي السؤال المايكرو سيركيليشن، يعني مفيش انترفنشن معين يقدر يدخلها يحسن الاوتكم.
قصدك المانجمنت يعني
مانج اوف مايكرو سيركيليشن اللي هي بيبقى فيها هايبرفيوجن وبتتدخل مع المايكرو سيركيليشن. هل في يعني اي ترايل قالت ان تحسين المايكرو سيركيليشن هيحسن الاوتكم؟
لا until now ما فيش، بس الترايلز بينت ان البيشنتس اللي عندهم poor microcirculation they have worse outcome.
يس يعني بروجنوستيك لكن مش ثيرابيوتيك.
بالظبط بالظبط. ويمكن اكتر حاجه هايلايتد في الليترشر هي الرول اوف فازودايليتورز. البيشنتس اللي عندهم early او pre-shock state they might benefit from vasodilators early on to try to reduce the systemic vascular resistance. بس طبعا ده لو البيشنت blood pressure will tolerate vasodilators even at smaller doses. لأن one of the causes of deterioration in cardiogenic shock هي over increase of the systemic vascular resistance but by very high doses of vasopressors, which can itself trigger systemic inflammation. احنا بنشوف patients عندهم cardiogenic shock refer to us وبيبقوا على super maximum doses of noradrenaline, adrenaline and vasopressin، ودول للاسف السرفايفل بتاعهم اقل.
يس في دراسات حتى جديده بتقول الهاير دوز اوف نورادرينالين بتعمل اثر عكسي، يعني we should go to the average. اللي مش هيجاوب يبقى اكيد ده irreversible.
بالفعل ويمكن هنا حضرتك دور الايمجنج بقى او الايكوكارديوجرافي early on in the process، لان فعلا الايكوكارديوجرافي can help determine البيشنتس اللي عندهم بري شوك ستيت، وكان help determining البيشنتس اللي في الايرلي ستيجز اوف شوك. ومن هنا بنقدر نديهم early inotropes بدل ما بنرش ان احنا نديهم vasopressors without knowing the cardiac output، اللي بالطبع will not help the microcirculation.
طبعا في سؤال من دكتورة جيهان بتقول early revascularization can improve mortality. I think
Yes.
yes.
Yes, this is probably the only thing we know until now from the research in cardiogenic shock, that early revascularization might help improve mortality and increase survival.
مش عارف حكاية المايكرو سيركيليشن دي بتضايقني لما بيتكلموا عنها ويتكلموا انفستيجيشنال ووقت الجد. طب ايه العلاج؟ ما فيش. بيفكرني دلوقتي في نيو استروجينيك فاكتور اللي هو LPA، وحتى الستاتين ما بيقللوش، وعمالين دراسات قد كده لكن لسه ما فيش دواء قدر يقلل LPA. فطبعا بتبتدي الحكايه كده وبعد كده هنلاقي ان شاء الله السيرابي
بإذن الله. ويمكن الأكتر حاجة يعني the message إن هو early identification is better. We should not wait until it is late. وأنا أعتقد إن الإيمجينج والإيكو ليه دور مهم في ال early identification of shock. وأنا يمكن شفت كذا مرة يعني في كونسبت في الشوك اللي هو الكريبتيك شوك، كريبتيك أو سب كلينيكال شوك. ده كاتيجوري من البيشنتس بيبقوا on the normal ward و appearing normal. يعني أنا مش هنسى بيشنت من كذا شهر كان في الهاي ديبندنس يونت، يعني مش في الاي سي يو، وكان fully awake. الاونلي بروبلم النيرس جت قالت لي ان اليورين اوتبوت بتاعه قليل شويه، فرحت عملت له ايكو لقيت ال في وتي في تي اي 10 سنتيمتر، يعني كليرلي هذا اللو كارديك اوتبوت. لكن على الرغم من كده كان اللاكتيت نورمال، البيز اكسس بتاعه نورمال، ما كانش عنده اي تاكيكارديا وما كانش هايبوتنسيف. فانا بيزد على الايكو بدات له اينوتروبيك سبورت، immediately started passing urine، و I repeated the echo الفي تي اي بتاعه improved ل 20 سنتيمتر. فاعتقد هو في اللحظه دي كان في early cryptic shock اللي احنا if we didn't catch it early بالايكو it might have been deteriorated, went into further fulminant or clear shock state.
ما هو ده برضه يبين اهميه الكلينيكال. لما الواحد لقى يعني ابتدى اوليجوريك وما كانش هو عنده اي رينال فيلير وبري رينال، يعني اليوريا طبعا بري رينال اللي هي الكرياتين ريشيو اكتر من 20، البي او ان على الكرياتين اكتر من 20، على طول بعرف البري رينال، يعني اعرف ان كدني هايبوبرفيوز، يعني اعرف انه بري شوك لاي سبب وبزود الفلويد، او لو ما استجابش بحط الانتروب. بس انت هنا عملت الايكو عشان تقول لا ده مش هيبوفوليميك، ده كمان كونتراكتيليتي والكارديوكوت قليل، بس ممكن الكارديوكوت تكون قليل بسبب هايبوفوليميا، فلازم ده يبقى هاند ان هاند مع الميجرمنت اوف فوليوم.
طبعا اكيد 100%. واكيد اي داتا بناخدها من الايكو بتبقى within a clinical context. clinical
ما انت برضه هتقول لي الترا ساوند بيحدد برضه هو مين هايبوفوليميك في الانفير فينا كابل كولابسيتي، مش كده؟
بالظبط. بس طبعا اهم حاجه كلينيكال اسسمنت، يعني الاساس هو الكلينيكال، والالترا ساوند بيسبورت الكلينيكال اسسمنت. absolutely.
تمام. مين هيسأل تاني قبل ما ننهي السيشن؟ حد له اي اسئله؟